that. We have an amazing panel, Sophie Friedel, who, I hope I get that right, Sophie, that who worked at the Senate Veterans Affairs Committee, Paul Sullivan, who is an expert on VA benefits and has also benefited from VA benefits, and is on our steering committee. Jasper Craven is our interim executive director, and he's doing all the technical work. And Russell Lemley, who is also co-founder and senior policy analyst at VHPI and was chief psychologist at the San Francisco VA healthcare system for many years. I'm just going to very, very briefly set the context. Way before the pandemic began, when telehealth really became critical, the VA was known as a global leader in telehealth. And I remember when I was writing my book, Wounds of War, how the VA delivers health, healing, and hope to the nation's veterans, sitting in a PT, a physical therapy appointment with a veteran in White River Junction when the PT was in North Carolina, and sitting in Fort Miley in San Francisco on an audiology appointment, and the veteran was in Honolulu, and it was really mind-boggling. And I had never experienced this kind of telehealth because nobody had it in the private sector. And of course, the VA has it and also has a national network that it can draw on. So it isn't limited to one city or state, but they can call on people all over the country to do these appointments. And they've done many studies. Russell will talk about them to look at telehealth. During the pandemic, the VA immediately was able to mobilize its vast telehealth capacity to move from in-person appointments to virtual appointments to protect staff and patients, and also was able to do that not merely because it had the capacity, but because these decisions were also wait, scratch that. That's not appropriate. Okay. The VA had 3 telehealth ICUs before the pandemic, and VA ICU and intensive care unit staff were able to help people all over the country through this telehealth capacity. And in July 2020, I mean, the New England Journal of Medicine, very prestigious publication, as you all know, did an article on VA telehealth, and I quote, it said, "The Veterans Health Administration offers a blueprint for rapid expansion of telehealth services during the COVID-19 pandemic that can be used to maintain those advances after the pandemic subsides." We'll learn also that VA provides devices to make it possible for veterans to use telehealth, because of course, in order to use telehealth, you have to have a laptop or an iPad or some kind of pad or phone. And if you're poor, these are expensive and very hard to access. But one of the things we're going to highlight, and really one of the reasons for this forum, is the fact that the Mission Act has created a double standard that Russell will explain, that peculiarly penalizes the VA for being a leader in telehealth. And we're going to talk about how to remedy that. So I want to begin by asking Russell Lemley to talk about 3 things. One is, why is telehealth so important, and how has it been documented to be effective? I mean, we are all now using telehealth. You know, I'm having an appointment with my doctor where, 3 years ago, I would have gone over to see him. Now I'm seeing him online. So how is it effective? How has it been proven effective, particularly in mental health? How is it effective, and particularly for suicide prevention? And most importantly, what is this double standard? I mean, why is the VA being penalized for being a leader in telehealth?
Thanks, Suzanne. Hi, I'm Russell Lemley. Let me see if I can take all three of those questions in sequence here. I mean, the first question really is the benefits of telehealth. Before COVID, two major ones, I think that wouldn't be a surprise to anybody. First is it reduces long travel for accessing care, especially for rural patients. The second is even when you have short travel distances, there can be other logistical burdens, for example, transportation, disabilities, childcare, and so forth. And so telehealth has been utilized for those two reasons. Then, of course, with COVID, virtual care minimizes risk of spreading the virus. So in a very rough way, I mean, those are really the advantages of telehealth. And as Suzanne was noting, is that VA has a kind of long history now, decades long, where they developed an encrypted HIPAA compliant platform. It's called the VA Video Connect, VVC for short. And Suzanne also alluded to the VA Tablet to Home initiative. At this point, the VA has provided tens of thousands of tablets and iPads to veterans. They come with data plans, and that's in addition to all the veterans that have their own connectivity on their own. So the VA is actually augmenting for those veterans that don't. And so, Sophie, I'm thinking you'll talk a little bit more about what the VA has done as well, because I'm going to pivot a little bit just to talk about mental health, telemental health. There have been 8 clinical trials that compare the effectiveness of telemental health to in-person psychotherapy. And in 7 of those 8 clinical trials, video telepsychotherapy proved as effective as in person. So we're getting equivalent results when it's being done by video. The research on telephone psychotherapy is not as extensive. So I think that the jury's still out that we can say as unequivocally as we can about the video telepsychotherapy, whether it's being done by phone, and a lot of it is done by phone. So smoking cessation being one example of where there's counseling being done by telephone. But if we're really talking about video, it's unequivocal at this point. Jasper, I don't know do you have the Rosen article you can put in the chat that does a good job summarizing what I just said?
Yeah, I'll do that right now.
Okay, thank you for doing that. Now, Suzanne, you were also asking a little bit about how telemental health helps with suicide prevention. You know, I think the first place to begin answering that is the way that the VA trains its clinicians on advanced emergency plans. It's worth noting that the VA requires, I'm going to underscore, requires telemental health training for all mental health and primary care clinicians. The reason it's important is not only that you can be assured that a VA clinician has had the training, but it's important because the clinicians in the Veterans Community Care Program have no requirement. So there's no assurance, like there is with many other things that we've talked about on other Zoom calls, that somebody who's working in the Veterans Community Care Program who sits down to do some form of telemental health with their patient has had any training. And the training I'm talking about here is just knowing how to make advanced emergency planning in the location where the veterans are sitting. So example, identifying an emergency contact person, knowing where local emergency services are available before you actually sit down to do the care. You were asking about suicide prevention, knowing where the backups are before, so you don't have to scramble in the middle of a session is important. All VA psychotherapists have been trained in that. There's another way, though, that I think we can also answer your question, which is that VA mental health clinicians are rendering the same, they're delivering the same psychotherapy via video that they are in person, in the office. And as we've said before, but I'll just say over 12,000 VA providers have received evidence-based psychotherapy training in mental health conditions. Now, you can compare that 12,000 with the fact that we don't know that any of the community care network providers have it because it's not required, it's not expected, and it's not measured. So the other way we can think about suicide prevention, in particular mental health care more broadly, is that we know that this is a higher level of quality standards that is occurring when a VA provider is on one side of a video psychotherapy than a non-VA provider. So Suzanne, let me pivot here, talk a little bit about Mission Act, as you said, and the double standard. But before talking about double standard, I just want to return to one of the things, Suzanne, that you said, which is that every VA provider is able to use telehealth to any veteran in any state from any state. It's what they call the anywhere to anywhere capacity. And what that means is that the VA has a capacity and often can provide telemental health very quickly. Because I could be sitting here in San Francisco if I'm a VA provider. I used to be. And be, as you said, I could be seeing somebody in Honolulu or North Carolina. All the places you said is that there is that kind of fluidity within the VA system for VA patients anywhere. And that expands capacity in terms of not only how many people are available, but how quickly they're available. Now, the Mission Act undermined the VA's ability to do that. And it had a destructive loophole in which the provision of telehealth, even immediately, even the next day, does not count as access to treatment for the new access standards. So veterans could receive telehealth quickly by VA, are still being referred to non-VA providers for telehealth. So this is in the essence kind of the double standard that was really undermining VA's ability. But I want to say there's a second piece of it as well, and then I'll finish up, which is that the regulation doesn't allow the delivery of telehealth to be considered within distance and drive time standards. So I was just talking about access standard a minute ago, but it doesn't allow it within the distance or drive time. So a veteran qualifies for care from a non-VA telehealth provider at home as long as the nearest VA facility was more than a 30-minute drive away. So the actual distance might be the next room in somebody's home, and they still qualify to get a non-VA provider just because the facility that they're not even accessing and not even going to is more than 30 minutes. Anyway, I will pause there, Suzanne. You're on mute. Suzanne, you're on mute.
All right. Thank you. Thank you, Russell, and we'll return to Russell in a little minute. I just wanted folks to know that I put in the chat a recent CBO study, Congressional Budget Office study on the Community Care Network, which for those of you who don't know, is really private sector healthcare. I actually object deeply to the use of the words community care network because it suggests that the VA is not part of the community, which I think is not true. But anyway, this study, to build on what Russell said, in this study, it essentially said that the quality of private sector care in the Veterans Community Care Program is not only unknown, but unknowable. Which I thought was quite interesting. So we're going to move to Sophie. And Sophie, Russell alluded to this, and I'd love to have you elaborate on it more, because there's an infrastructure needed for the delivery of telehealth. And you are very well versed in the way that the VA has built this infrastructure, and we as taxpayers and citizens have paid for it. So could you talk about that?
Yeah, so you guys have talked about how VA has been doing this for a long time, and that is so true. VA actually first had their very first telehealth appointment in 1960 over video. So this is something that VA has been doing for a very, very long time. They have since, even in 2013, they were doing 1.3 million, 2017, about 2.5 million, up until 2019, about 2.7 million video calls, video appointments, or telehealth appointments, telehealth, which can be video or phone call appointments every single year. And then that even expanded so much more during the pandemic. But VA is an old hand at this, and they've spent billions of dollars every year. Their most recent budget request for the Office of Connected Care is $2.5 billion. So they've invested a significant amount of money into providing this telehealth care. And like Russell said, they've also invested not just actual dollars, but also a lot of time in building up partnerships and relationships. So VA's Anywhere to Anywhere initiative, which started in 2017 under then Secretary Shulkin, is incredibly unique. We got to see a glimpse of what that could look like in the private sector during the pandemic when a lot of the state regulations were waived. But basically, VA can provide telehealth, whether or not you're in Honolulu, Anchorage, Alaska, even in the Philippines. You can provide telehealth if you're in a federal facility anywhere to anywhere. And in 2017, they allowed that into people's homes as well. So there was an NPR article that came out yesterday. NPR did a story about how those rules are starting to get rolled back for the private sector because during the pandemic, they waived a lot of those state requirements for telehealth, and those are starting to get put back into place. So VA's supremacy in that area is kind of coming back as well. Some of the really innovative programs that they've done are like the Atlas initiative. So they're actually putting telehealth pods into rural VFW, American Legion posts, and rural Walmarts. So veterans can walk in. It's a partnership with Philips and see their VA provider really close to home. So I actually got to visit one when I was working for the Senate. It's up in Eureka, Montana, which is in the far, far northwest corner of the state, only 10 miles south of the border with Canada. It is an hour and a half drive, depending on weather conditions, away from the nearest CBOC, let alone VAMC. So it's very rural, but veterans still now get to see their providers. And what's great, especially in those rural areas, for the Atlas program specifically, is that even if you lived up there, you may not be able to get telehealth to your home because of the lack of broadband infrastructure. So VA is really going the extra mile and having this hub exist so that even if veterans don't have internet access in their homes, they can still get access to VA care. They're also doing this by distributing iPads. Like Russell said, they've given out over 50,000 iPads to veterans all across the country so that they can have access to VA's Video Connect program. They've also worked a lot with all of the major mobile broadband providers. So that's AT&T, T-Mobile, Verizon. They have partnerships with all of those carriers so that if you're using the VA Video Connect app on your phone, you're not paying any data. So if you only pay for 2 megs of data every month, your VA video visits don't count towards that. So VA is putting in the effort and has been for years to really make sure that their telehealth infrastructure is meeting veterans where they're at. And something interesting that Russell said as well is HIPAA. So there's a reason why your doctors still use faxes and won't let you email them is because of HIPAA regulations. And you have to have a really secure, encrypted video or phone line if you want to be able to provide telehealth. And that's very expensive. You have to source that. You have to maintain it financially. So VA already does this. VA already does this in-house. So it's very expensive to kind of operate this telehealth. So when veterans are being sent out into the community to get telehealth from a community provider, VA is pretty much paying for that care twice because they've already put all this money into infrastructure for VA to be able to provide telehealth. And now they're also then paying for the veteran to go out into the community and reimbursing the private sector provider. So it's kind of a double cost in that regard. VA, and it's not just the Office of Connected Care. So I've been talking about Office of Connected Care, and that's the tele-ICUs, like you mentioned, Suzanne. That's the VA Video Connect, but it's also the kind of operations support, right? So if you're on a call, if you're a VA provider and you're on a call with a veteran, you have a direct line to somebody if that phone call gets cut off or if you're having technical difficulties, there is an in-house VA person who can help you with that. Whereas in the private sector, you may be calling, the help desk of some large conglomerate. It's, you may get them tomorrow and maybe they'll fix it then. Whereas VA has that in-house. So they're paying full-time staff to assist in the VA Video Connect arena. But it's also all aspects of VHA. So the VA Office of Rural Health funds hundreds of $millions every year for innovative kind of last mile resources for veterans. So it really focuses on rural veterans, and a lot of that goes into telehealth. So it's not just the fact that the Office of Connected Care is funding telehealth. Lots of other offices within VHA are also funding telehealth care. So that's just kind of some of the infrastructure that VA has put into place around telehealth. And like Russell mentioned, they've also put a lot of time and effort into training their providers to be able to provide telehealth. Because I know I've had some telehealth visits. I'm not a veteran, so it's all been private sector providers. And sometimes the providers are good and know what they're doing with the video connect, and sometimes they don't. So having somebody who actually is trained on how to provide care in a video or phone call modality, I think is really important as well.
Thank you, Sophie. So Paul Sullivan, you are not only a cherished colleague, but also a veteran, and you have had telehealth experience. I wonder if you could talk about, from your point of view as a patient, what that's been like.
Oh, thank you, Suzanne, and thank you, Russell, and thank you, Sophie. Yes, I'm a veteran. I'm a Gulf War veteran, and I'm in priority group 1 at the Department of Veterans Affairs. That means VA will cover all of my care. And I was surprised, and happily surprised, that a few months into the COVID pandemic, VA called and they wanted to say, hey, we want to check on you. Are you doing okay? Do you need anything? Are your medicines refilled? And I was like, wow. First they called, and then they set up the telehealth appointment, and it all went very well. And then 2 other things happened, which were great. There's specialty care. They also set up some telehealth appointments. An alarm just went off right next to me. I'm so sorry. And then VA also set up my COVID vaccine appointments. So VA wins. VA did great. And I was pleasantly surprised, and it all worked. So what I want to say to everybody out there listening is that VA was ready, VA did it, and it worked.
Yeah. And did you find the telehealth visit different from an in-person visit, in the sense that you know, it was not only more convenient, but I mean, you didn't have to worry about waiting in the office because you were in your home and that sort of thing?
I actually thought it was great because I have underlying health conditions, and I did not want to go to a large VA hospital or even a large doctor's clinic where I could be around people who are either unvaccinated or potentially sick. So for me, it was the fastest, it was the safest, and it worked out to be the best. And it was actually really easy. You know, I'm getting old now. All I had to do was push a couple of buttons, and I was right into the call. And I have to say this, in all fairness, they were on time. It was great.
Yeah. Thank you so much, Paul. So I want to turn the last part of the discussion into the remedies for this kind of penalizing of the VA and double standard. And I know we've all thought a lot about this. And I'm going to ask particularly Russell and Sophie to talk about it. And Paul Sullivan, if you'd like to chime in, please feel free. But Russell, why don't you begin about how can we end this kind of double standard?
You know, I'm happy to do it, but Sophie, I almost feel like if we're talking about Title 38 and we're getting down into that level, because that is how we can fix it. I'm happy to have you lead, and I'll come in after.
Great, fine.
Sure. So in terms of brass tacks, we're talking about the Code of Federal Regulations. So obviously we've got the Mission Act signed into law, but that gets implemented through VA's rulemaking process, and that is in the Code of Federal Regulations. And in the code, it does say that telehealth should count as an appointment. But we've heard a lot of anecdotal reports from veterans that VA is calling them, and unlike in Paul's case, where they were able to get him a VA telehealth appointment, they're offering community appointments right off the bat. Or they're, not, it's kind of difficult to know the availability of telehealth appointments, because they are unlike kind of traditional doctor's appointments where you block off 30 minutes of time, and once you get 8 hours of your day scheduled, then you're full. Telehealth appointments are a lot more dynamic because you can pull in providers from lots of different places. VA has 10 telemental health hubs. They have 8 primary telehealth hubs all across the country that specialize in doing these appointments. So it's a little bit more difficult to ascertain what the real kind of, I guess, appointment wait time would be for a telehealth appointment until you try to get it scheduled. So that makes it a little bit more challenging to really know what the wait time is. And so veterans are being kind of offered these community appointments. And during COVID, it made a lot of sense for some of those appointments to be virtual, right? We don't want to send people into places where it's unsafe. But if VA can provide those telehealth appointments, VA should be providing those telehealth appointments. Unless this is like part of a continuing episode of care that's been with an outpatient private sector provider for a long time. If this is your first mental health appointment and VA can provide it through telehealth, and if you're going to have to go to the community, it's also going to be through telehealth, that should be provided in the VA, because VA has those really specific capacities that the private sector just doesn't. You know, the private sector is not an expert in MST or PTSD or TBI in the same way that VA is. So it's an implementation issue within the VA, but it's also kind of the nuance, like Russell was saying, of the drive time versus wait time standards. Because telehealth is such a unique modality, and because VA has the capacity across the country to be able to provide it, they should be able to provide these appointments, right? I can't tell you that it's the wait time for a telehealth appointment is 4 hours, because that's just not something that VA tracks in that way. But VA has the capacity to be providing these appointments. I know from working with the VA Montana, lots of VAs have same day mental health access. If you come in for a primary care appointment and your primary care provider says that they think that you need a mental health consult, they will bring in a mental health provider to come and speak with you that day while you're there for your appointment. And in Plentywood, Montana, it's all virtual. It's all it's an entirely virtual hub. And so veterans will come in, see their provider virtually. And if their primary care provider says that they need a mental health appointment, they will get a mental health appointment within the hour. Like, I know that they have a Skype group where they talk to each other and figure out which mental health provider can go talk to that veteran in Plentywood, which is in the far northeast side of the state, almost in North Dakota. So this is something that VA absolutely has the capacity to provide. It is kind of a regulation issue. It's an implementation of those regulations. And it's also kind of tracking. So VA has a difficulty tracking their own telehealth appointment availability, and they have absolutely no visibility of appointment availability in the community. There's zero visibility on wait times for community care providers. There's also very little visibility on drive times. So for rural veterans, if they live far away from a major metropolitan area, odds are their private sector provider is also going to be in the major metropolitan area where the VA is. So they may have to be driving the exact same distance to get to the private sector provider as they are to the veteran, or to the VAMC or CBOC. So there's it kind of runs into some difficulty when we're holding VA to this high standard and there are essentially no standards for the community providers. So Russell, I feel like I kind of talked a lot, so anything I missed, feel free to add in.
Well, I just want to go back to your very first point, which is that there is already in regulation, I'm going to quote it, that says appointment means an authorized and scheduled encounter, including telehealth and same-day encounters with a healthcare provider for the delivery of services. It already exists that telehealth could count as an appointment, and that would satisfy. VA from the beginning for the last 2.5 years has elected to not count that. But that's an election that has been happening in the VA that started 2.5 years ago and then continues. So if there's a fix here, it's just for VA to pivot and really understand that is to do the thing you said that they've chosen not to do, which is to know when an available appointment through telehealth is available. And if it's within 20 to 28 days, then that would satisfy the access standard. Now, they've elected not to, but they actually already have the regulation in place where they could do it.
So,
and in fact, and let me just say, I think that what Suzanne introduced is that if there's one thing to come out of this Zoom is the hope that there is a revisitation of the way in which this particular regulation is being interpreted so that we're not losing, and particularly in mental health, because this is where it's particularly egregious, that when there's capacity for mental health, that in the hundreds of thousands of appointments that are going out into the community that could be delivered within the VA.
So I just want to add one piece of information and then ask a question. And I put this into the chat, but the studies are pretty clear that private sector mental health providers are not educated in evidence-based practice, particularly for things like the PTSD and military sexual trauma, but also many other things. It's kind of scary as a private sector patient to think of the lack of training that one gets when one goes out for help. But I also think that there's an issue in capacity in the private sector that was not considered in the Mission Act, and hopefully will be considered in the Asset and Infrastructure Review Commission. But there's a real shortage of mental health professionals. There's a huge shortage of mental health professionals who will accept insurance, something like, I may have this wrong, but it's slightly less than half of psychiatrists won't take any kind of insurance at all. If you're trying to find somebody who does cognitive behavioral therapy, which is one of the gold standards treatments for PTSD in the San Francisco Bay Area, it's very hard to find a psychologist trained in CBT who will accept insurance. So if you happen to have 20 grand under your mattress to pay out of pocket, and then you can hope that some of it may get covered by insurance. But also there's just a huge shortage of mental health professionals. I mean, 55% of American counties have no psychologist, psychiatrist, or social worker. So I wanted to throw that out, but I really wanted to hone in on this pivot. How do we get VA to pivot? I mean, do we need a letter from the VSOs? Do we need veterans to be calling the Senate and House Veterans Affairs Committee? Do we need letters to Secretary McDonald? Do we need legislation? I mean, how do you make the pivot? How do you get the pivot to pivot?
I think that's a yes and. Yes, I think the VA needs to be aware. Yes, I think SVAC and HVAC need to be aware, the Senate and House Veterans Affairs Committees. And I think this is a great forum for introducing people to why this is a problem. Because ultimately the reason that it matters is, yeah, it's going to cost more. Yeah, we want to see more veterans be able to get access to care within the VA, because if they have a choice, it should be a true choice, and it shouldn't be a choice between an underfunded VA because they've had to send all of their money to the private sector. So it should be a real choice if that's something that we want to give veterans. But the reason it's a problem is because of fragmented care. Today myself, I had to call 3 different doctor's offices because I had to get blood drawn for my allergies, and LabCorp said that they faxed it and then they didn't fax it. And I was driving between 3 different locations and had to figure out where my blood test results were. And that took me an hour and a half today that it wouldn't have had to take me if I went to a doctor, they did the blood draw there, they had the results in the same system. So if, I have a life-threatening allergy to shellfish, and if I had been first diagnosed today and nobody told me that I had a life-threatening allergy to shellfish, that's death. You know what I mean? So it's that care fragmentation that makes it that is why it's bad to consistently send veterans out into the community. And then it's also the quality, like you were mentioning before. I think that CBO report does a really great job of laying out all of the data about, there have been lots of studies that show that VA care is superior than private sector care, or at least the same as. There's not the kind of evidence out there that says that VA doesn't do a good job. Obviously, there are some patients where that is not the case, and they have bad experiences, but that's also true in the private sector too. But the private sector doesn't have the same magnifying glass on it as VA does. So I think, you know, I know that I see Alexis on here. So I know HVAC now knows that this is a problem. I see VSOs on here. VSOs are now knowing about this issue more. And I think also, you know, VA, there's a lot of things that VA is required to do under the Mission Act. And so they have had to prioritize what they want to implement in whichever way they decide to do that. So by continuing to bring up this issue with VA, whether from if you're an individual veteran, whether you're with a VSO, whether you're in Congress, and making sure that this becomes a top priority in implementing the Mission Act, I think that's all really important. Because then once a change happens, then there also has to be steps down the line, right? It can't just be a change in regulation and that's the end of it, because VA then has to go through and educate all of their staff, their frontline staff who are making appointments, their physicians, everybody in the VA needs to basically know how to properly handle veteran appointments. This happened with veterans with other than honorable discharges, and I know you guys have done a really great job of highlighting that. But that was a messaging issue. You know, that was a communications issue. And even though Big VA was saying, OTH veterans, come get your care here, if you're a receptionist at a CBOC in a rural county in Georgia, where I currently live, you're not going to, like, OTH veterans are going to get turned away. So regardless of what Big VA's policy is, that has to be communicated down to the frontline staff.
So I'd like to just sum up and then open it up for questions. So we're pretty clear that, I mean, it seems to me kind of a no-brainer, although there's a lot of brains out there who haven't gotten it, but that we need the same standards for the private sector and the VA, but also that VA telehealth should be counted as appointment, as access for many reasons, and that Big VA needs to get on this issue. I mean, one of the things I didn't mention is that we have been privy to information that in any number of medical centers, VA medical centers areas, that veterans who are sent to the community for mental health care are waiting months for private sector appointments in telehealth, which is the easiest kind to get because there just isn't the capacity in the private sector to accommodate so many veterans. So that's another reason it's delayed care. Care fragmentation, I think, is an issue that people are just not taking seriously enough. I can't really go into this, but I have a friend whose son just died at 35 of care fragmentation, literally dead, because doctors weren't communicating and there was drug interactions and he died. I think we need clearly education. We also need broadband in rural communities. So this is a very solvable problem. I think you all agree. This is a very solvable problem, and it's common sense. So I'd love to open it up to questions. You can put the questions in the chat. I'm not very good at this, so maybe Jasper, if you could help me, but I guess you can raise your hand. I'll just start with one that's in the chat from Dana Almond. I believe beyond writing letters to the VA and congressional members, we need to get this emphasized in the media, on camera, et cetera. My recent experience with getting issues that affect our daily lives in the media, I felt it made a major positive impact. Dana, do you want to say something with your voice about this? And I'm not sure how we do that, but.
Yeah, can you hear me?
Yeah.
Hi, everybody. Yeah, my name is Dana Allman, and I'm with a group called Common Defense, and I know that we know how to mobilize, organize, and I'm not going to speak on Common Defense for them, but I've learned from them how to get issues out there and make a major impact. And recently, I'll share that I was one of the 5 veterans that resigned in protest from Senator Sinema's Veterans Advisory Council. And 3 of us that resigned have been in the media. And I saw a couple of things change all of a sudden. So, when someone is saying they're not for something, you get in the media, all of a sudden they change their tune, and I'll leave it at that. But I'm willing to help in any way that's possible. I've drafted up my own Senate bills, and I've gone to Congress with a coalition of private citizens, veterans, and military academy graduates. So I already know how to get to some folks that have the power and offer my help.
Thank you so much. Thank you, Dana.
Do you mind if I add quickly to that? I completely agree with you. And I think there's actually an article in USA Today just last month about how the Mission Act was failing because it wasn't sending enough veterans out to community care. So I think getting articles that are favorable to VA is probably more difficult than getting articles that are criticizing VA. And I think that there needs to be a more balanced presence in the media that includes, stories of positive impacts that VA has. So I completely agree with you. And I think that's a really impactful statement.
And then the follow on is I'm the co-chair of the Southern Arizona Veterans Mental Health Advisory Council. So mental health is a big deal for me. And what I've been able to do is out here in Tucson, I'm from Arizona. I am now linked in with the director of the hospital out here because I'm on her Veterans and Family Advisory Council, and I've briefed her on many things. And also I'm linked with the chief of mental health at Tucson VA. So our council is able to link in with the VA here and help out and advise them and make a lot of awesome changes out here. So again, I'm also familiar with that.
Well, thank you, Dana. And we should be in touch about how maybe we can work together around this telehealth issue. And I have your email and maybe we can do that offline. Jeff Steele has a question here. VA has put a pause on Atlas expansion as they do a review of the program. No explanation given. Any idea? Anyone? Dana, Russell, do you have any ideas about this, knowledge about this, or?
No, sorry.
Okay. Are there, let me see, are there other questions?
David Cooley has his hand up.
Great, David.
Hi, thank you for taking my question. My question goes to both the VA and community care. It seems to me that it would be better could those initial appointment or appointments be in person as opposed to telehealth. Because I think there's a whole different interaction that occurs when we're in person with one another. And as a clinician trying to figure out what's going on with a veteran or not going on, if they have no history with the veteran whatsoever other than what they see on a screen, it may not give them enough of a clue. I always say if we communicate with more than our words and more than just our faces. And there's a whole lot of communication that gets missed. And it seems to me that obviously telehealth, I use it all the time. I think it's really great. But I think those initial appointments, if possible for both, should be required to be in person. Thank
Russell, thank you, David. Russell, do you want to comment on that?
I do. And I love the sentiment, David, that you're bringing to this, which is that no matter what, there's something that cannot be substituted from an in-person contact, something deeply, basically human. And that if you're talking about psychotherapy, which I think was where you started, that's a human exchange in addition to all the other clinical aspects of it. So I think your sentiment is right. However, with that said, I think the VA's position is probably going to be that it's a veteran choice, whether it's telephone, video, or in person once they know whether they qualify for VA or they qualify for outside of the VA. I'm guessing that they're not going to require, which was the verb you used, that it has to be in person first if, for example, it's 200 miles or whatever the other reasons are. So I think they will appropriately encourage getting to know your provider. And I think there's a little bit of research that says alliance is better when you've had some in-person contact. That also said, though, I was talking earlier about the clinical trials that at this point say that the video telepsychotherapy has equivalent results. What you just said is exactly what I was saying 6 or 8 years ago. You were quoting me that I'm a therapist. I used to think exactly as once you have a relationship and alliance, then it's easier transition. I've actually migrated, and particularly the research is driving me faster into the recognition that you can get nearly equivalent results. So,
yeah, I think that all David Cooley and Russell, I mean, I think it's also very dependent on the person. I find I'm not in the VA. I wish I were, but I wish I could get my health care. I know exactly who I'd go to, but I can't. But I've had some telehealth appointments with my primary care doctor, and obviously I had met him earlier, but I find it extremely interesting because I feel that it's almost the only modality where there's an equality. Telehealth gives it a kind of equality because you're in your space, they're in their space. And I don't get white coat hypertension when I'm talking to my doctor over the phone, if he keeps me waiting, I don't get regular hypertension, because who cares, he obviously doesn't get hypertension because he knows that I'm home and I can wait comfortably. I think telehealth is extremely interesting, but I also think that, the major thing here is to get this settled. Denny, you have your hand up. Denny Riley. Denny, you're not.
I got it. So, I agree with what's being said there about meeting your physician, but I recently had one physician leave, and a new one I was going to talk to, and it was going to be a phone call. And I welcomed that because of the kind of guy I am. I would walk in and the doctor would say, "How are you doing?" I say, "Great. How are you doing?" And we go through all that kind of nonsense. And I thought, and then I'm really this egocentric dude who wants people to like him. And that's not the point. And so I thought, I made a little list of what's my problem. And when the doctor called, I went right to that. And it was a much more valuable call because I cut out all the in-person joy, Anyway,
That's very interesting. Yeah. So we have Rene Campos, who says, as an advocate from personal experience, veterans are often left on their own to determine what community provider they want to see, with little or no understanding as to what constitutes a good or qualified provider. Rene, would you like to say a little bit more? We'd love to, in terms of making this a more virtuous virtual experience. How would you like to say a little bit more about that?
Well, I think there's still a lot of problems. I've certainly experienced that this year in terms of just using community care as a whole, or actually in the last year and a half. And I see things are getting better, but I think even within the mechanics of internally how VA goes from you as a veteran seeing your mental health provider and then transferring it over to community care. The Office of Community Care within the medical center is just, focused on getting that appointment. And so as a veteran, you're either pushing them to try to figure out what you need to do. And if you're good enough and what criteria you're looking for, let's say you want to see a provider in the community that sees veterans, that see women veterans, or so on. And I had that criteria, but the VA couldn't direct me to that in the community, and they would send me over to the contractor, and they would just say, well, we're just, we're at the phone level, and, do you have somebody in mind? Fortunately, I did. But again, I think that there's that disconnect of even the warm handoff internally within VA. And then going to the community, the veterans kind of left on their own. And the other piece I don't see, which I think goes back to what Sophie was saying and you all are saying, is that this needs to be, especially with mental health, it needs to be really integrated. And you don't necessarily see VA coming back and following up to see if the care you're getting in the community is quality and working for the veterans. So I do think that a lot of this gets back to what you're going to do next. Really, we have to have data, and I think that it sounds like from discussions today that we really, maybe VA doesn't even have a good handle on the numbers of people going out into the community. And again, what is that quality of care? What are the outcomes of those patients? So, or those veterans. So I think that's important in determining also a path forward. So thank you.
So I think that, I just have to throw in something here, Renee, and thank you so much for those insights. I think the Mission Act is essentially a mission impossible because there simply are no granular metrics to answer questions about the individual competence or capacity of individual providers, right? We don't have those kind of quality metrics, whether in the private sector or not, right? And we have some of that in the VA. And the issue of care coordination, you would have to have, I don't know how many more staff you would have to add to the VA to get care coordination with the private sector, which doesn't, by the way, do care coordination with each other. Sophie just described her experience. I'm 76, a little older than her, so maybe I have more problems, which I've accumulated with age. You have to be your own care coordinator in the private sector, and they don't want to give you information. So, I think we really actually have to rethink this whole enterprise. If you want a coordinated care system between the VA and the private sector, in my view, you need a national health system, because that's the only way you're going to get it. But I'd like to close asking.
But Suzanne, this is Russell. Let me do 20 seconds here just to follow up on what Renee was saying. If you go onto the Optum Provider Handbook website, you'll see that they explicitly have no quality metrics for mental health and behavioral health. They've right from the get-go said they're not going to measure it. So the thing that you were saying, how could you find that out, is already being written off as unimportant in the way that the regulations state. And so the contracts have to change to require Optum and TriWest to actually have some quality metrics on their care if you're going to get the information, because right now they're given a free pass.
Well, and you might want to add something, Russell, about the idea of how Optum and TriWest define high-performing networks.
I think that's another conversation. Let's do that another Zoom. But
okay, we can have another Zoom on quality.
Do you want to give a minute to Daniel Young before you close? Because I think he's been waiting.
I didn't see his. I'm so sorry. Yes, Daniel, could you?
Oh, hello. I think community care in my case has been a failure. And I put all my confidence in the VA. I don't have confidence in community care, especially TriWest. I think that they're just in it for the money. And I think that we should be going more towards universal health care and less again towards for-profit healthcare, which is what community care is. They just want to get their hands in the pockets of the taxpayer. And I've found that the dental part of community care is like a black hole for a dentist. And they'll come up with, or my dentist came up with a list longer than both of my arms of things that needed to be done. And the list was looked at by the VA, and they rejected a bunch of the stuff. And then the dentist said, well, I don't want you as a patient. And it shocked me, but I'm not surprised now, because after listening to all of you folks, I understand how complicated it is and how much it could get thrown out of kilter and away from the intent. So that's why we need people like you, Dana, and all of the rest of you, Russell, and Susan, and Sophie. I really admire the work that you're doing. I appreciate the opportunity to speak up on this Zoom meeting. The last thing I want to say is that I wish that my wife could have access to VA care, not community care, but actual VA care, because the VA has been so great for me. The people are kind, they're patient, and they know their stuff. And the TRICARE is just like, they're a bunch of, well, I won't use any derogatory terms unless referring to them as a bunch of unorganized children is derogatory, because they don't treat me, they never treated me as a veteran. I was just another number. So there's a whole lot of work that needs to be done with community care. It could possibly work out someday, but I think we'd be better off if we just went for universal health care. Okay, well, thank you everybody for hosting.
Thank you, Daniel.
Just
Thank you. You're freezing up a little bit, but I would love to conclude by just giving Russell and Sophie a chance to say a final word, particularly if you could focus on just reminding folks the path forward. I mean, what do we need to do now? What are next steps? Russell?
I would just say briefly that some of the actions that came up earlier, and Dana, I was very heartened by how much you just jumped right in, and we will be in touch with you to coordinate. But for everybody else, whatever actions you decide to take, either individually, collectively, I would ask that you let Suzanne and I know, because obviously this is an issue that we think needs attention and would make a great impact in a positive direction if we can just get this regulation tweaked in the right direction.
Thank you. And you can email us at, I guess, VHPI. Maybe.
Yeah, I just put my email address, execdirector@veteranspolicy.org, in the chat, so anyone can follow up there with me, and we can take next steps together. I also gave a link to our website where you can read our policy analysis, become a member or a subscriber to our newsletter, etc. So thank you all for coming. This has been really
And Sophie, do you want to have a last word? Is Sophie gone, or is Sophie?
I'm still here. Don't worry.
Kick us forward, Sophie.
Well, I definitely want to echo everything that Russell said, and I so appreciate all of you guys being here today, because that shows how much you care about veterans and how much you care about keeping the VA strong. And it is your guys' efforts, along with, helpful direction from VHPI or whatever other organization you're associated with, that really makes a difference. It is that collective, that collective group of people that can really make a bigger impact. And kind of like what I said before, the VA has a lot of priorities, and making sure that they're aware what veterans consider the most important is what their mission is about. And so by raising your voices and letting, if you're a member of a VSO, letting your VSOs know what you find the most important. You know, if like Dana, if you are able to work with your local VA, they have a chain of command as well that goes all the way up to central office eventually. You know, it is really, you know, all politics is local. So start where you have a sphere of influence, and that's where how we can kind of build that larger national support.
So I want to thank everybody for coming, and we will probably have another Zoom that we'll let you know about in December. We invite all of you to go to the website and to subscribe to our newsletter. And also, if you all feel like donating 5, 10, 15, 50,000, you know, would be much appreciated. And again, we're so thrilled that you've all come, and I think this was just a great forum. And we hope to see you again soon. Take care.
Thanks, guys.